So in this section, we are going to discuss pain assessment and management in the pediatric population. A lot of it is stuff you've learned previously in fundamentals and throughout med-surg, pharmacology. In children, there are a little bit different ways. Sometimes we either assess pain or treat pain. So as you see on the screen, there's a lot of the things that cause us pain cause children pain as well. They're pretty obvious. A problem, though, sometimes in the pediatric population is the under assessment as well as the under treatment of pain for people who aren't as aware of how to take care of those patients appropriately when related to pain. So you also see this with doctors because they do get concerned, and we're going to talk about pharmacology related to a treatment of pain, but they have a lot more chance of being unpredictable in side effects as well as how they'll tolerate the medications. So you have to be a little more careful in the dosing as well, but sometimes that can cause problems of their pain being undertreated. So when we're talking about assessment of acute pain, all of you know the 0 to 10 scale used in adults. Starting at about the age of 7 or 8 years old, a child can understand how to use that 0 to 10 scale. So we use it a lot in pediatrics as well. Remember, pain is what the patient says it is, just like in adults. For those children that are younger that maybe can't understand that numerical rating scale, we have other methods that we use to help evaluate up till starting at about the age of 3. They can start using what we call the FACES scale. And I know many of you have seen the FACES scale in this picture. It is the one posted on the right-hand side. You see these posted in doctor's offices. They'll have smiley faces. They'll have teddy bear heads, Lego heads, all different types of pictures they'll show. But this is easier to understand because they can point to the picture of how they're feeling. They can better show that connection with them in that picture than trying to understand what 0 to 10 means. And if you're talking about a 4-year-old, they don't even know their numbers sometimes. So asking them 0 to 10 is not going to be very effective. Younger than 3, we use what's called the FLAC scale, which is the one on the left-hand side of your screen. This is what you call a behavioral scale. So use this in infants and toddlers. When they can't even understand how to point to a picture, you can use their behavioral cues to determine whether they're in pain. And FLAC stands for face, legs, activity, cry, and consolability, the 5 sections that are listed on your screen. And it's based on how they're acting in each section. You get anywhere from 0 to 2 based on that behavior. And then you give them an overall score that will end up being 0 to 10. So it's still on like a 0 to 10 type scale, but just evaluated differently. Again, starting at around age 3 is when they can start using the Lego pain scale, or not the Lego, the FACES pain scale, and then around 7 is when they can start actually using the 0 to 10 number scale. Something to take into consideration. Again, developmental level is the most important consideration when you're worried about this, or when you're using and caring for patients. Just because a patient is, say, 10 years old doesn't mean they're cognitively able to handle that. So if you have a patient, for instance, with autism, they may not either be able to express if they're nonverbal, or they may not even be able to understand. Just because they're over 7 doesn't mean it's necessarily appropriate. The same goes in individual situations. For instance, if they've just had a surgical procedure and they're still drowsy, or they're on medications that make them drowsy, even if they're 8, 9, 10 years old, they still might not be able to comprehend that 0 to 10 scale, and that's where you can go back to that FACES scale, for instance. Don't forget, it's not just about the intensity of pain that we're worried about. You need to take in that whole PQRST assessment. So you're looking at things that make it better, things that make it worse, what it feels like, the quality, whether it radiates, does it travel anywhere. The S is that severity, and that's where you use those scales. And then the T, the timing of it. Does it come and go? When did it start? That kind of thing. So then you have chronic or recurrent pain. There are children that experience chronic and recurrent pain as well in different situations. For instance, juvenile rheumatoid arthritis. They are very much associated with pain. So the kind of Chronic and recurrent pain are often put together, but they're not the same. Make sure you know the difference in chronic pain and recurrent pain. So chronic pain is something they have every day. So every day they have pain, whether it be arthritis or like if they've got a brain tumor, they may always have a headache or something. Recurrent pain is where it lasts over a long period of time, but it comes and goes. They may only get that headache every 3 or 4 days, but they've been getting that headache every 3 or 4 days for the last year, for instance. So that's where that chronic and recurrent pain requires a little bit different assessment associated with it. Just like we do in adults, you have to worry about with chronic pain, not just how it's affecting them as far as being in pain, but how it affects their daily life, how it is affecting their psychosocial and their physical ADLs. So as far as pain management, y'all know about non-pharmacological management of pain, so I'm not going to go into it in too much depth. We use a lot of similar non-pharmacological things as we do in adults, like distraction and relaxation. You can use guided imagery in children. Drawing is an excellent, you find drawing, coloring, playing, writing, all those can be used not only for communication, but also as a distraction method and a way to release their frustration. The picture you see on the bottom left is what you would consider continuous stimulation. So this is a device called the buzzing bee. We would use these at KidMed, and it's part of that gate control theory of pain. Do you remember talking about that back in fundamentals, where you're closing the gate on the pain? So what the purpose of this buzzing bee is it distracts those nerve receptors so they don't feel the pain of what is going on. So the blue part you see that are the wings of the bee is actually a cold pack that attach, and then the bee itself actually vibrates, so they get a vibration and a cold sensation right above where that painful procedure is taking place. So it's supposed to block those nerve receptors. I've had some kids say it works, some don't. I've definitely never had any kids smile at me like that little girl's doing while she's having it done, but you know. And then there's some other methods of non-pharmacological management that we also use are your CAM therapies, those complementary and alternative medicine therapies. Some people refer to them as your Eastern medicine type of therapies. So CAM therapies can be pharmacological, but in the non-pharmacological realm, we're talking about it can be like your acupressure, your acupuncture, even special diets. And we'll actually talk about this when we get to neuro. Some people use the ketogenic diet for various things. Gluten-free diets sometimes have been shown to help people that have chronic pain, like for instance, people with like fibromyalgia and stuff like that. So there's various different methods we can use as those non-pharmacological pain managements. So then we'll look at the pharmacological side, the drug side that we use to treat pain. The most common ones we use in pediatrics is acetaminophen, which is not an NSAID. It does not do anything for inflammation. It is simply for fever and for pain. And then you have your non-steroidal anti-inflammatory drugs, or your NSAIDs. The only one of the NSAIDs we use in pediatrics routinely is ibuprofen. We never, ever use aspirin in children for fever disorders or pain related to that. The only situations where aspirin is used in pediatrics is for Kawasaki disease and rheumatic fever, which we're going to talk about later when we get to cardiac. But overall, aspirin is never used because of Rye syndrome. And again, we're going to talk about that. But Tylenol or acetaminophen and ibuprofen are your only two options. We don't even use naproxen, naproxen, Aleve generally in that population as well. So we do use opioids occasionally with pediatrics. The problem is with peds, again, with their immature system, sometimes they have trouble processing those drugs. So it could be they process them quicker and they need higher doses, or more oftenly it's where because of their immature kidney and liver function that it actually stays in their body longer and they're more at risk for side effects. So generally the way they approach medications, especially like this in the peds populations, is to start at a low dose and kind of work their way up to an effective dose. The most common opioid that is used in pediatrics is actually fentanyl. Make sure you know that fentanyl is the most common opioid used in pediatrics, and the reason for this is because it has a rapid onset, it's much quicker onset than some of the other opioids. It also has a much shorter half-life, which means even if they're having overdose type symptoms, respiratory depression, whatnot, it's going to get out of their system faster. And of course, I know you already know this, but make sure you have naloxone at the bedside or readily accessible in any patient who is receiving opioid therapy. And this goes for adults as well as children. So opioid side effects, make sure you know the side effects of opioids. You'll be expected to know those. Sometimes we use adjuvants or co-analgesia. This is where you use medications together to make those pain medications work better. For instance, in Excedrin. Excedrin has acetaminophen and it has caffeine in it because the caffeine acts as an adjuvant and actually increases the potential of the Tylenol working. So that's why they have that. Or like people will often use like anti-anxiety medications to help with that pain. And then you have the patient-controlled analgesia. Some of you may have seen this where they actually have a button they can push to control the amount of analgesia, just like in pediatrics though. Pediatrics, just like in adults, only the patient should be pushing that button. The parent shouldn't be pushing it and the nurse should not be pushing it. It needs to be controlled by the patient if there's a button to control it. Now, you will see sometimes where younger pediatric patients like infants and toddlers are put on a PCA pump, but they're only getting a basal rate, meaning they're just getting a small continuous rate of medication and there's no additional method to give them an extra boost. And that's okay. When you're giving them that extra boost, though, they should be old enough to be able to understand and do that. They can do that at relatively young ages, sometimes 4 or 5 years old. You kind of give them a time frame of, like for instance, if you're in pain when the next every time a commercial comes on, go ahead and hit that button, and that gives them an idea of how to time that out at the way it's timed. And epidurals, we don't use them a lot in peds, but we do use them some. The picture you see here is called Emla cream. We use that a lot as a topical anesthetic. So it's not a pain reliever, it's not an analgesic, it's an anesthetic because it does block those nerves at the superficial level. But that can help with things like giving sutures. Sometimes we can, especially on the face, because it's so readily absorbed on the face, they can actually not even have to get injected lidocaine for sutures because it works that well. So make sure you know the difference in physical dependence, tolerance, and addiction. So the difference in these is tolerance is where they need higher and higher doses of the drug to be effective. It's not when they stop having side effects. Like for instance, if you take Benadryl on a regular basis, a lot of people say it no longer makes them drowsy. That doesn't mean they have a tolerance to it. It just means that they're not having the side effects from it anymore. Tolerance is where you need higher and higher doses for it to be effective. So with that Benadryl, if you're having allergies, for instance, if you have to keep going up on the dose to get that allergy relief, that would be a tolerance, not where you're losing those side effects or expected side effects. And then you have physical dependence and addiction. Addiction is psychological. So addiction is where you have this psychological need to have a substance, versus physical dependence is where you actually have withdrawal symptoms, is that physical attachment to that substance where they will have side effects associated with this. So next we're going to talk about chronic illness, disability, and unfortunately end-of-life care is a part of every part of nursing, including pediatrics. So because of our advancing medical technology, we're seeing more and more, especially pediatric patients with chronic medical conditions. If you see this baby right here in this picture, I would guess that baby is probably about 24 to 25 weeks gestation, maybe 26. Very tiny baby. We in the United States, well, I think worldwide, but especially here, we are able to save babies in maintain them as early as 22 weeks gestation. That's like halfway through the pregnancy. So you're getting more and more babies who are being born younger and younger as far as gestation. So you're having more and more children with chronic health problems. Chronic health problems sometimes are lifelong. And they can be very expensive because you not only have the expenses of the medical aspect, but oftentimes they need special care in all aspects of their life. They may need a private nurse, or they may need private schooling or a certain type of school to go to, so they can become very, very expensive. Chronic conditions encompass a lot of things. It just means something that's ongoing. It could be congenital anomalies they're born with, like cardiac defects, for instance. It could be genetic disorders like cystic fibrosis, for instance, sickle cell disorder, phenylketonuria or PKU. Those are all genetic disorders. It could be acquired disorders. If they are in a car accident, for instance, and have a traumatic brain injury, that could result in chronic complex disease for the rest of their life. And it can happen anywhere in their body. So in the newborn, a screening panel is done to test for genetic disorders. Make sure you know about those genetic disorders. We will cover them again when you get to maternity, or if you've already done maternity, you talked about it. But in your pediatrics ATI book, it also talks about some of those genetic disorders. So we do talk about it in pediatrics as well, like PKU, for instance, understanding the implications of why it's important to know if you have that, because it can result in severe deficits. And a lot of the stuff that's done on newborn screenings, the reason they pick those specific genetic disorders, because they tend to be disorders that don't always have a lot of symptoms up front, but have devastating consequences in the back end. So for instance, PKU or phenylketonuria is an intolerance to phenylalanine, which is found in meat products. It's also found in some of your artificial sweeteners, for instance. And oftentimes they're not going to have signs of that intolerance like you would think of with some GI problems. The problem is it builds up that amino acid breakdown and results in retardation, or not retardation, cognitive delays and all later on in life. So one approach that you have to take with all chronic patients and families caring for their children is normalization as much as possible. You want to create the most normal life as you can for this child. This includes in hospitalization. You want to maintain their routines as best as you can. And you want to maintain that what they're used to. But another aspect is to also promote normalization at home for the parents. Tell them if they can be mainstreamed into activities, it is best to do that. If a child wants to join Girl Scouts, or if they want to join a sports team or some kind of club, it is best to promote them being as mainstreamed as possible, because they still have the same social needs as every other child. So coping with that ongoing stress, you remember back the Kubler-Ross stages of grief. We're going to bring that back around again. So the first thing with that coping is they're going to have some shock and denial. They're not going to really want to accept it. No, there's no way my child has that. They might go looking for second opinions, things like that. And then they're going to have anger, and that can be anger that's outlasted other people. It can be anger at themselves. And oftentimes it is anger at themselves, like if I had done something differently, and they'll have that self-blame with it. Then after they've gone through that, they'll have that adjustment period where they're able to find ways to cope and reintegrate back into their environment in an appropriate way. And you'll find, just like when we talked about Kubler-Ross back in fundamentals, they'll go back and forth, especially at certain life stages. Like they'll go back through that shock and denial phase and that depression phase for when that child is either hitting milestones or supposed to hit milestones. Like when you have a child that can't go to school and they're supposed to go to kindergarten, or you have a child that should be graduating from high school, getting married, all those things. They'll go back into that period of shock and denial. Well, it'll seem like they don't remember any information that they were given. They didn't realize it was going to be so bad. They didn't realize they they did know it, and they'll even say later, I know it, but they go back through those Kubler-Ross denial stages. So educating about the disorder, again, that anticipatory guidance is key in a lot of things, and especially when you're talking about chronic illness. There's probably going to be a lot of modifications they have to make that they may not have even taken into account. Like, depending on the disorder, the child may need a special car seat or something to allow them to sit in a car. They may need wheelchairs. They may need other devices to help them ambulate or even help with their ADLs. So getting those into, getting those resources for those patients is very important. So here is a list of the psychosocial stages of Erickson's, just as a reminder. So you're going to have to focus on, again, that development, determining how to treat the patient and what to focus on based on their stage of development. You want to, a lot of it is going to be independence, especially once you get to that school age group. And then in adolescence, that's going to go even further. So you want them to be a part of their care as much as they can. You also want to make sure you're establishing discipline with those chronic patients, and as well as letting them be a part of their care, letting them have some kind of control when they can. So at the end of life care, we do have end-of-life care for pediatrics. It's not as prominent as adults, but it is something to consider. The care is the same. It is based on palliative care or quality of care, making them as comfortable as you can in all the ways that you can. Some die at home. Some die in special rooms in the hospital. They actually have, for patients that are on hospice or they're preparing for death, at MCV they have a room that's the palliative care room, and it's decorated more so like a room in your home. It has low lighting, it has regular furniture, and it's made to be as comfortable as possible. Make sure you know the signs and symptoms of impending death. They're talked about in your book. We talked about them in fundamentals. You'll need to know those signs that indicate that death is nearby. You need to be honest with these children. They know something's wrong, and oftentimes parents especially don't want to tell their children that say they have cancer or they're dying. But children know, even if they don't know exactly what it is, they know something's going on. So you can help them by being as honest and forthcoming as you can. So interventions that we do for pediatric patients, again, a lot of the things we do is very similar, but there may be a different approach in the way we do things, and we're going to talk about those little bit of differences. So I already talked a little bit about consent. So it does vary from state to state, but in the state of Virginia, for emancipated conditions, those psychiatric substance abuse conditions as well as sexual related conditions, they can give consent without their parents at the age of 14. And you can't give that information to the parent. They are treated as a separate entity, just like you would any other adult, where you're not going to be sharing their information even with their parents. Now, we do encourage those children to talk about it with their parents. And if they say, I want you to tell my parents, then we can, but we have to get that consent from the child at that age. They are legally able to provide their own consent for those medically emancipated conditions. Now, emancipated just means separated, basically, or in a different situation. So you can have emancipated minors too, where they are completely, they have legal paperwork to say they are viewed in the eyes of the law as an adult, and they are also exceptions where they can sign their papers. But ultimately, otherwise, if a child is under the age of 18, the consenting person must be the parent or guardian. And that's where you can have some issues when you've got 16, 17-year-olds where the parents want one thing and the child wants a different one, and those can create some problems. Hopefully they can work together, but ultimately it is up to the parent. When you're talking about informed consent, y'all know the needs for informed consent if you're doing blood products, surgery, invasive procedures, whatever it be. Those either invasive procedures or things that have a great potential for injury are going to require informed consent, that actual written consent. The parents can refuse. I've had several parents that refuse blood products. We actually see quite a bit of Jehovah's Witnesses. If a parent refuses or does not want to sign a consent, you cannot force that procedure on them unless you have a court order. So you as the nurse cannot say, I'm going to do it anyway. The doctor can't say, we'll just do it anyway. You have to have a court order from a magistrate to say, yes, I'm forcing you to give this blood product. And then you can give it. That's the only way you can give it when a parent refuses, or whoever the person that is able to provide consent will not get consent. And I've had people who are on both ends of it. On Jehovah's Witnesses, again, like I talked about way back in fundamentals, don't assume that because they're a Jehovah's Witness they're going to refuse blood products. I had one mom who their hemoglobin was in the toilet, and when we explained it to her, she said, I don't like this, but I understand my child's going to die without it. I want you to, she consented. Versus we had another Jehovah's Witness who, and she was very pleasant about it. But she said, my religion, I understand they are going to die without this blood product. I personally cannot give that consent. I will not fight you if you get a court order for that consent, but I personally cannot be the one to consent to that. I just can't allow myself to do that. And you have those situations, and you want to work as best as you can with these people to make sure they're getting what they need and what they want. Again, if you are talking with a teenager and as a separate situation where they're not with their parents, you want to make sure that privacy is maintained. In the state of Virginia, like I said, we can't give those test results to the parents. So ensuring that those kids know that we're not telling the parent those STD results or things like that, for instance. So when we're preparing for performance of procedures, again, the same things we talked about regarding the communication. So a lot of those same things that you see on the screen. You want to make sure you're involving the parent and the child. You want to make sure you're honest. That's a huge part of that. You need to take the time to establish that trust. Don't just walk in the room and start taking care of the patient. You have to take that extra time with pediatric patients to really talk to them and get to know them before you start poking and prodding at them. Another very important thing, like I mentioned before, is to give them choices when you can. Again, be very careful about what choices you give them. If you ask them if they want to take their medicine and they say no, technically you did not give them a choice. Even though you made it sound like you gave them a choice. But when you can, it's good to give them choices. For instance, do you want juice or milk to drink after your medication? Distraction is great. We use bubbles all the time, and singing and counting and telling a story and all those things while painful procedures are going on. And it really does help distract them for a lot of children. So guidelines for preparation by developmental group, you can see this. Again, a lot of these are the same things I talked about regarding communication when I talked about it in the beginning. When you're talking about parents, make sure you're using formal names. Just like we talk about in fundamentals where it's not okay to use honey and sweetie and all those pet names for patients. You also shouldn't be calling the parents like mom, dad, their first names. You need to show that respect by at least addressing them first by Mr. Jones or whatever. And then when they tell you, no, call me this, then you can go with that. Make sure you're always including the child. It's very frustrating when I see people only addressing the parent. Even at 2 and 3 years old, they can give some insight into what's going on with them and give you an idea, and they need to be a part of that process. When we're talking about surgical procedures, pre-op, You're going to orient them to the environment. Orientation is a big key in anxiety with children, with hospitalizations in general, making sure they can touch the equipment. And again, this is going to be, use some common sense on based on what equipment that is. Probably not needles, but like the blood pressure cuff and the stethoscope and stuff like that. If they want to wear some of their own clothes, let them do that, especially in your late preschool, early school age group. They have this big fear of taking their underwear off. It's that little thing that ties them to that familiarity and comfort zone. So if they want to wear certain things, let them wear it, as long as it is not contraindicated for their medical care. It's certainly encouraged and allowed. Making sure you're going by appropriate NPO parameters. This is something that was talked about in med-surg, as far as we don't really do the straight NPO after midnight or NPO for 8 hours before procedures. And it was actually started in the pediatric population where they started doing this, because take infants, for instance, they would go 8 hours without eating and then they're very dehydrated. So that's why it's more of a tapered, and you don't need to memorize this chart, but seeing how it's tapered in the sense of what your heavier foods you have to stop at 8 hours, but you can have thinner foods and then liquids closer to that are going to be exited out of your gastric system a little bit faster. If you forgot malignant hyperthermia related to surgery, go back and review that from med-surg. Malignant hyperthermia is they have a genetic predisposition to having a reaction to certain muscle relaxants used in the OR, like succinylcholine is a common one. It causes changes in those calcium channels. Their metabolism revs up. So that's where that hyperthermia comes in. But actually that temperature change is a very, very late sign. What you really want to be looking for is that muscle rigidity. Related to their symptoms, usually hypotension and tachycardia are the first thing you're going to see. So you'll see almost like those shock-like vital sign changes, and then right after they may start having the muscle rigidity. So treatment for this, you're going to give them dantrolene, which is a muscle relaxant. It'll help relax that muscle rigidity, and you're going to use active cooling measures to cool them off. You don't use acetaminophen or ibuprofen for this, because this is not inflammatory related hyperthermia, which means for instance, ibuprofen works on the prostaglandins that are released by the hypothalamus. There's no prostaglandin release related to this, so it's not going to help with the cause of that hyperthermia. So some safety measures related to the hospital setting. These are really not that different, again, from adults. Keep crib rails up at all times. That's the same as keeping the side rails up on the bed. You'll often will use bubble top cribs. And I have a picture for that of you on a couple slides from now, where it has a plastic covering, and that keeps toddlers and preschoolers from being able to crawl out. Make sure the crib is pulled away from things that they could potentially harm themselves with, and they get very good at doing this. I had a 3-year-old one time. I had made sure the pump was pushed away from the bed, and that the crib rails were up. But this little sneaker had used his IV tubing to roll the pump over to himself and was trying to push buttons. One thing I also did to make sure he couldn't change anything was I locked it. Most pumps have a lockout option on the back of the pump for children and patients that are trying to adjust their rates. So he wasn't able to harm himself because I did take those safety measures in place, but he did figure out a way to, try. They're very smart. Making sure that medications are kept out of the reach of the child, and ultimately they should be locked up. And this goes for home teaching them about home care. Make sure you're teaching patients that harmful substances should be not just up high, but they need to be locked, because kids are smart and kids are monkeys, and they will climb up to where they need to get to it, so they can still get it if they're determined enough. Preventing cross infection. Generally, the toys that are used in the hospital, they're used from patient to patient, need to be wipeable. You're not going to be given stuffed animals, for instance. It's going to be those hard plastic wipeable toys. And you also want to make sure they're safe. So the general rule of thumb we use for safety of toys is if it can fit through a toilet paper roll, the middle of the toilet paper roll, then it's too small to give to a child under the age of 3 because it's considered a choking hazard. Another thing we worry about is toys that could break, where pieces could break. So I mentioned some of that family teaching already. Making a safety is a big part. What you actually teach is going to vary depending on the age and the developmental level of the child. But I already talked about a lot of these choking hazards. They're at a fall risk as well. Every patient in the hospital, when it comes down to it, is at a fall risk just because of changes in their environment. And then infection control. So nosocomial infections, there's about 2 million per year, meaning these are infections they got from the hospital. So if you don't remember your types of precautions, make sure you go back and review them and you know the standards of standard precautions, airborne precautions, droplet precautions, and contact precautions. Generally, anything that's on the skin or anything that's GI is going to be a contact type of situation. The one difference is RSV, even though it's a respiratory infection, it's actually only contact. It's not droplet. A lot of your droplet infections are going to be your respiratory infections. Droplet meaning when it's released in larger particles, so it's only about a 3-foot distance that it's a problem. Then you've got your airborne. The easiest way to remember the 3 big ones related to airborne is MTV, you know, like the TV show, measles, tuberculosis, and varicella, and those are your biggies. The airborne, where you wear the duckbill or the N95 mask and they're in a negative pressure room. Whenever you have a question where a patient has some kind of infectious process going on, I will tell you the first priority, nursing priority, is going to be isolation. So if you have a patient with meningitis, for instance, while yes, assessing that they are doing okay is important, but it's not your priority. Your priority is to make sure it doesn't go to somebody else. So this is that bubble top crib I mentioned. As you see, it's got the plastic overlay on the top. Now I will tell you the middle of it is actually open. There's not like a ceiling to that. So I have seen kids even come up over that top bar and try to climb out. So they really know how to climb around. Just like in adults, we want to use the least amount of restraints possible. Restraints are viewed a little bit different in pediatrics than they are in adults, because sometimes we have to use like temporary restraint methods, like when we're just holding them for a procedure, or when they have an IV, for instance, we'll put an arm board on them to keep their arm straight. Technically, that's a restraint device. So we try to limit restraint devices as much as we can. So in this instance, that picture A that you see on your left-hand side, we use that a lot where we wrap them up in blankets, we swaddle them, and you can pull one arm out like when you're doing an IV. It's a really good way of swaddling them. Another good way, although they tend to have a little more anxiety about, is the one that's on the bottom right-hand corner. That's what we call a papoose board. We use papoose boards a lot for restraint methods, and it's got the straps that Velcro over them, and it works really, really well. And then y'all have seen the wrist restraints. I'm sure the one at the top. The bottom is elbow restraints. So all it does is they can still move their arms at the shoulder, but they can't bend their arms at the elbow. So we use this a lot, for instance, if they've had a cleft palate repair or surgeries on the face. That way they can't pick at the sutures. So sometimes we'll use those. We try to limit restraint use as much as possible, though, just like in the adult population. So collection of specimens is going to, there's a couple ways it's a little bit different. Collecting blood and stool and respiratory secretions are no different than adults. The one you see down at the bottom, the nasopharyngeal swab, we'll use that for flu as well as RSV, and a lot of times you can do it off the same swab. Those of you that have had a flu test done, you know exactly what it's like, and it's no different in children. As far as urine is the one I really want to point out that's different. If a child is potty trained, again, it's the same clean catch urine that you would do in an adult. But if they're not potty trained, that's where it gets to be different. So if ideally the best way to get a urine is by a catheterization, a straight cath, especially if you're looking for a culture. So the picture you see at the top is what we call a urine bag. And I'll show you an example of this in class. So it's a bag that sticks on around the urethra and collects that urine when they pee. Ideally, it would be a great idea, except it's not the cleanest way you can do it. They fall off easily, they leak, they get contaminated. So ultimately, if you need a really clean catch urine or a sterile urine, a catheter is the best way to go. If you need small amounts of urine frequently, you're not going to cath a child, for instance, every couple hours if you need to check every urine. And there are instances where you do need to check every urine that they pee. For instance, when patients are on chemotherapy, you check every single urine to make sure their pH is okay, their specific gravity is okay, they're well hydrated, there's no blood. Some chemotherapy agents will cause you to have ketones in your urine. So depending on what chemo you're looking for different things, but the pH and specific gravity are with every chemotherapy. So you want every urine, but you're not going to keep cathing them all the time. So what we do for that is the cotton ball method. Know about the cotton ball method. You put cotton balls in their diaper, and the cotton balls soak up the urine when they pee. And then when the urine is in the cotton balls, you use a syringe to aspirate that urine out of the cotton balls and then drop it on the dipstick for the urinalysis. The reason we don't pull it right out of the diaper, if any of you have ever opened up a diaper and seen the gel that's inside of the diaper, it's extremely absorbent. So more than likely, you're not going to be able to pull any fluid out of it. Even if you do, though, it's so absorbent that it's going to alter that specific gravity, and you're not going to be have a really good specimen for that. So medication administration. Two things that we do, and you already know this from your dosage calculation. We do weight-based dosing, and we do body surface area dosing. There are no standard doses of medication in pediatrics. It is always based on, because giving a 2-year-old a medication is very different in dosing wise than giving a 15-year-old a medication. So you have to have a way of determining how much they should get. Just like with everything else, you want to make sure you're using your 2 patient identifiers. You want to make sure you're letting the parents and the child know what's going on. All those same things we do in the adult population. Making sure that you're thinking about their liver and their kidney function, especially in your infants. Their liver and kidney function is going to be diminished because they're not mature yet. So they might have some problems with elimination and excretion of those meds. They may hang on to them a little bit longer. So they may have an altered dose because of that. So when you're administering oral medications, you want to, with infants, you hold them in a semi-reclined upright-like position, like a feeding position. Older kids, you can put them upright. Ideally, you don't obviously want to lay anybody flat to give them meds. Sometimes it happens, but you increase that risk of aspiration. So when you're administering it, you administer to infants an oral syringe, and that's that second picture on your left, down at the bottom. So when you're giving it to infants, you insert the syringe on the side of their mouth along their cheek, and you squirt it in that way. And the reason we do it that way instead of straight in the middle is they can use their tongue to push that medication out. They do that tongue thrusting and push that. So if you go along the cheek, it's less likely that they'll be able to use that tongue to push it out. Some other very important things to think about when giving children medications: you don't want to mix medication with ideally anything. You definitely never mix it with something they need for nutritive value, like breast milk and formula and milk and stuff like that. Ideally, you shouldn't even mix it with juice. And the reason is, if they don't finish it, you don't know how much they got. So if you give them 4 ounces of juice and mix the medication in, and they drink only 2 ounces and refuse to take the rest, yes, they took half of it, but you don't know if they actually got half of the medication depending on how it was mixed, and you can't dose comparatively to hope you can give the right amount. So ideally, it shouldn't be mixed with anything. If you mix it with anything at all, it should be something very small that's sweet to cover the bitter taste, like maybe a little bit of applesauce, or a little bit of honey if they're over the age of 1, of course, or a little bit of ice cream or something like that, but something that's very small, like just a little bit that'll fit on a spoon. and that's all. And another important parameter is you make sure you're using a accurate measuring device. And make sure you're telling your parents this too when you're doing discharge instructions, just telling them to give a teaspoon of something. They may go grab the teaspoon out of the kitchen drawer and it's not the same. They need an appropriate measuring device. Along the bottom you see the graduated medication cups that I'm sure you've seen in the hospital. You have the oral syringes that have the markings on them, but there needs to be a way to accurately measure that. And then IV devices. You've learned about IV devices. We use the same ones in pediatrics. At the bottom right is that portacath, or that PAC that we use, that implanted port. You got the central line up at the top and then at the bottom that we often give when they need continuous therapy. One thing that varies just with peripheral IVs is we have a little bit more areas of access in children than we do in adults. We use the arms, but we also use the feet up until walking age. Generally, if they're walking, we will not use the feet for an IV because of the risk of it becoming infiltrated and dislodging. And we use the scalp as well. And I know people think scalp IVs look horrible, but they're actually great IV sites. Sometimes they're less traumatic than some of the other ones to children, and they work really well. And then optic nasal administration. Remember, when you're administering in the ears, adults are taller than adults. Adults are taller than children, so you're going to pull the ear up and back. Children under the age of 3, down and out. And this is when you are assessing their ears as well as when you're administering, and that straightens the canal so the medication get into the best spot. As far as eye drops, if any of you have ever tried to give eye drops to anybody, not just babies that are forcing their eyes shut against you, trying to open their eyes, it can be very tough and sometimes almost impossible. An easier method, just for your FYI to do this, is laying flat on their back while their eyes are closed. Just drip it in the lacrimal sac right in the corner, and then when they open their eyes, it will fall down into their eyes, and they can get it that way without being so traumatic. So aerosol therapies, like your inhaled devices, we use spacers religiously in children. In fact, I don't know of anybody who orders an inhaler without a spacer in the pediatric population anymore. They're actually at MCV now, they're using, instead of nebulized albuterol, they'll use that inhaler and spacer of albuterol. The child takes 6 puffs at a time, which is equivalent to 1 nebulized treatment, and it's more effective. They're getting more of the medication that way, and they're finding better results that way. So NG, OG, gastrostomy administration, these are no different than in the adult population. You do worry a little bit more about clogging just because the tube is smaller. Oftentimes they have 6 French, 8 French tubes, and these are very small tubes. So making sure, important implications with this is to make sure you're not giving meds with formula, because they can congeal together, and also making sure that you are crushing it adequately. It needs to be a fine powder. It can't have any chunks in it. And you also want to make sure you're flushing before and after that med, so that med's not coming into contact with that formula. So the last chapter we're going to talk about here is the impact of cognitive and sensory impairment. Some of these, again, will be a review of adults, like hearing impairment, for instance, and a good portion of this is going to be new. So it used to be we referred to patients with cognitive impairment as having mental retardation, or MR. They found, obviously, this is not the post-PC way to address these patients. So now they have used cognitive impairment, or your ID, intellectual disability. Both of those are used where they have some kind of impairment. And there are, if you look at the right-hand side of the screen, there are tons of things that can cause this. For instance, intrauterine infections. Rubella and varicella are well known to cause cognitive impairment as well as hearing deficits in children if the mom is exposed while they are pregnant. So it can be genetic disorders like Down syndrome, or again, that PKU, that phenylketonuria, if they don't recognize that that child has it and that child is ingesting those meat products, that phenylalanine, it can result in that cognitive impairment later on. It could be an injury. An injury doesn't always mean traumatic. You think of injury as trauma, but injury can be lack of oxygen. For instance, oftentimes babies, well, not oftentimes, but babies may have a anoxic brain injury, meaning there was something that happened to cause them to have lack of oxygen. It could be what's called a nuchal cord, where the umbilical cord's wrapped around their neck. It could have been something with the placenta, but for some reason they were cut off from oxygen, and this resulted in tissue damage to their brain because of that hypoxia. So injury doesn't always mean trauma injury. So there are lots of things that can cause this. We use standardized testing like your IQ testing to determine levels of cognitive impairment. And the reason this is important is because you can best meet their needs with finding the right resources for them. Depending on their level of cognitive impairment, they may still be able to hold jobs and go to school and have formal training, versus some that have lower or much more severe cognitive impairment may have to actually be placed into a facility. So nursing care of the children with impaired cognitive function, again, like I've said a couple times, caring for all children is based on their developmental level, not their chronological level. So you want to make sure you are gearing your care towards whatever level they're on cognitively. Even if they are 18 years old but have the mind of a 3-year-old, you're going to treat them like a 3-year-old. As terrible as that sounds, but that's how they're going to understand. So commonly with cognitive impairment, they often have difficulties with verbal skills associated with it. It just so happens a lot of those causes, whatever caused the cognitive impairment, can also cause language problems. So they may need additional assistance with that, with using sign language and using picture boards and stuff like that to help. This is why regular physicals are so important in children. Children should be going, when they're an infant, they go every 2 months. After that, they go every year, because those doctors can recognize those disabilities early, and the earlier you get treatment, the better the outcomes are going to be. So the first specific disorder related to cognitive impairment, actually the only one I'm going to discuss specifically cognitive impairment, is Down syndrome. It is one of the most common genetic causes of cognitive impairment. So you'll hear it called trisomy 21 because the most common genetic defect that causes Down syndrome is where you have an extra chromosome on that 21st. There are other ways, as you see it's listed here. You don't need to memorize those actual causes, but you see sometimes it's a translocation or a mixture. One huge risk of Down syndrome is late pregnancy. So after 35, you are considered to be a geriatric pregnancy. Nobody wants to be a geriatric anything at 35, but they classify you as a geriatric pregnancy because the risk of so many things, including Down syndrome, significantly increases. So you're labeled as a high-risk pregnancy at that point, and they'll monitor that. So diagnostic evaluation is often based, or at least initially based, on those facial characteristics. They have some very distinct characteristics usually in Down syndrome, and there are varying degrees of them, but they often have the flat bridge of the nose, the low set ears. It talks about in your book all of those manifestations that are associated with it. Make sure you know about those. One of the biggest concerns, though, we worry about with Down syndrome, not just the cognitive delays, but the physical problems. They have a much higher rate of cardiac disorders, specifically like septal defects. They have a much higher rate than the general population of leukemia. They also have a high rate of hypothyroidism, so monitoring for that. So autism, I said Down is all because autism actually, there are lots of children with autism spectrum disorder that are very intelligent and don't have cognitive impairment. They just have difficulty expressing themselves. So we no longer call it autism. We call it autism spectrum disorder. In the bottom picture, it shows you all the different things that have been placed under that umbrella of autism spectrum disorders. But we call it a spectrum disorder now because there are so many varying levels of severity. You can have what used to be called as Asperger's syndrome, and you still hear it called that way, where it's a very mild defect. Some children you can't even tell where that they have it until you actually look into some of their behaviorisms a little bit more detailed, versus you can have severe forms where they are completely nonverbal and non-functioning on their own. So there are extremely different variances in how severe it is. So the symptoms of autism are all related to socialism, communication, behavior, language. They all kind of fall under those. They often also have difficulty with eye contact and body contact, and that kind of goes in that socialization. You'll find where they're staring off at something else. They can't look you in the eye. They do not like to be touched. I don't know if any of you have watched the show The Good Doctor. If you haven't, I highly recommend you watch it. It's about a doctor who has autism, and he displays some of those behaviorisms really well. They don't like to be touched. Sometimes they'll have language delays, sometimes not, but they have trouble. They don't understand social norms. They'll say things that are not part of the conversation. And usually this is diagnosed around the age of 2 or 3. So if they're not showing, another thing you'll see is they don't ever establish that social play. So it's normal when you're 2 or 3 to have that parallel play where you just kind of sit next to each other. Two kids are playing but not playing together. Versus after that point, usually you're going to have more social play where they continue not to play with others. And that would be considered something they would want to look at. They don't have that magical thinking and that imaginary animism and all that stuff that you think of normally with children in that toddler and preschool age. They don't exhibit that. They're very almost like concrete, very literal. So care and management is going to be based on symptom management. It can be severely disabling. There is no cure for it. It is still unknown what the cause is. There seems to be some kind of genetic predisposition. They just don't know what it is. The importance of that, again, is to recognize that early through those regular yearly visits. They can do behavioral therapy. Sometimes they'll use medications, such as for things like calming behavior, like they may be on a risperidol, for instance, that helps with some aggression that can form and things like that. They can do special diets. I mentioned the ketogenic diet for neuro disorders. The ketogenic diet, where it's a very high fat, low carbohydrate diet, has been shown to be effective sometimes in their behavior as well. So there's various treatments for these patients, but there is no cure to actually get rid of the disease. So in the ears, the picture you see here, that outer ear canal is all the way to your left. That middle part is what we consider the middle ear. And that's where when people have otitis media, which is typically where ear infections are when somebody says an ear infection. And then you've got the internal ear, which goes in towards the throat structures and all. So you have two main functions of the ears. Hearing is obviously a big one, and balance as well. So sometimes when people have ear infections, they may get some vertigo, for instance. If you look at the bottom picture, I know you've already read about this in your growth and development stuff, but one of the things that puts younger children, infants and toddlers, at much higher risk of ear infections than adults. If you notice the eustachian tube in the two pictures, the infant's eustachian tube is very straight and narrow. So things can get caught in there when they have nasal drainage, for instance. It gets stuck up in that eustachian tube and it's not able to drain. Versus in the adult, it's angled a little bit higher so things can drain a little bit better. So with acute otitis media, this is a middle ear infection, inflammation of the middle ear. Most of the time when it's infection, it is a viral infection. However, doctors will treat this always with antibiotics, especially in the population under the age of 2. Why would they be treating a virus with antibiotics? Because in case it is a bacterial infection, the reason we worry about otitis media in the younger population is that especially if they're getting recurrent otitis media, it leads to scarring. This scarring can lead to hearing loss. So we worry about affecting their hearing for the rest of their life. And on top of that, not only can it affect their hearing, but if they're not talking yet, it can also affect their ability to have verbal skills later on. So some signs and symptoms of ear infections you may see: rubbing or pulling at the ear. They may shake their head side to side. They may slap at their ear. When you're talking about the infant population that can't really express, of course, crying is obviously a sign that they're hurting. If they're older, they may say their ear hurts. They may have sudden hearing loss, especially if they rupture that tympanic membrane. And they can have various things that go along with that. The picture at the bottom is a picture of a tympanostomy tube. So these, when people get ear tubes, you've probably heard of people getting ear tubes. That's what that tube looks like. It's a very tiny tube, and usually they make it a bright color so you can pick it out, like orange or green or blue are the ones I've seen. And it allows this outlet so the drainage can come out. The fluid can be regulated and not get built up in that middle ear. So treatment for this, again, is broad spectrum antibiotics, and they may do those ear tubes if with those recurrent otitis media situations, because you don't want that scarring to occur where they end up having problems with hearing. Some important parameters about giving antibiotics in general for infections. 1, make sure you're instructing them to take the entire prescription, even if they're feeling better. And you see this a lot with ear infections, respiratory infections. They start to feel better, so they stop the medication. And unless you complete it, you're going to develop superbugs, and that can cause it to recur. So you want to make sure they're taking the entire prescription. So with hearing loss, this can develop from ear infections. It can develop from a lot of things. It can develop from ototoxic drugs. Remember way back in pharmacology when you talked about those antibiotics, those aminoglycosides like gentamicin, those can result in ototoxicity and hearing loss. O2 administration sounds kind of weird that would cause hearing loss, right? Well, and this is something we'll talk about with infants. Sometimes when we give too much oxygen, especially in the NICU population, it can cause problems because it causes constriction of those vessels. Like you can get blindness because of that O2 administration, because it constricts those vessels. So we have to be very careful about how much we're giving. And various other things, like I mentioned, rubella as a perinatal infection can cause hearing loss as well. So the manifestations are listed here. They are also discussed in your book. A lot of times the first sign in an infant that they have a problem is the lack of startle reflex. And that's where that startle reflex is where they look like they jump out of their skin when they hear you coming. And it's a protective mechanism. If they're not doing that, it means they didn't hear you. If they're not starting to babble when they should, if they're not starting to develop those verbal skills, that can be a sign. If they're not, even in infancy, when they're not talking, they should at least be turning their head towards somebody that's talking to them or towards noises. And if they're not doing that, when they get older as a child, those speech difficulties are often the first sign. When my son was put into speech therapy, the first thing they did was do a hearing test, because that's most commonly the causes of those speech problems. So there's various management for hearing therapies. What you see in here is a cochlear implant where it's implanted and transmits that signal for them, and has shown great outcomes for these patients. But other things you may see using lip reading. Make sure you read in the book those ways of using lip reading, such as, making sure that you are using those lip and facial movements so they can actually see what you're saying, making sure you have good lighting, make sure you're close up to them, using short phrases. Those are all important things to include with lip reading. There's also devices that they may use for hearing impairment patients at home. Like, for instance, there are ways to turn light into sound. Or turn sound into light. I'm sorry. What I mean by that is, like, when the telephone rings or the doorbell rings, they can actually have flashing lights attached to that so they can see the lights. You can use picture boards where they actually point to what it is that they want, like it's shown here. Even if they can't communicate verbally, they can point to what they need on the picture board, and that gives them a way of communicating. If they're old enough to write, give them a dry erase board as well. So when we're talking about the eyes develop very early. Newborn sight is not mature. Technically, newborns are legally blind when they are born, and it gets sharper and sharper. Color, they see best. Actually, they see sharp contrasts like black and white in those primary colors. Those pale colors we use for newborns just don't work. They can't even see them. Babies do not actually produce tears until 1 to 3 months of age. So if they have tearing as a newborn, that's actually probably a sign that they have a blocked tear duct. It's not normal for them to have tears. And then they develop, it progresses throughout as they get older. By the time they hit 6 or 7 years of age is when they'll have that 20/20 vision. So visual impairment, again, there's lots of them. Infections. If you've already taken the maternal part, you know this. If you haven't, you'll learn this. Chlamydia and gonorrhea are huge causes of infant blindness. So what happens with chlamydia and gonorrhea, and when you go to the clinical site, you'll see this. They give every baby optic erythromycin, the gel they put in their eyes. And the reason for this is erythromycin is very cheap. And it's better just to treat every baby for this than suffer the rest, because chlamydia and gonorrhea, the most common symptoms of those STDs is actually no symptoms at all, especially in women. So women may have these STDs, not realize it, and then when baby passes through that birth canal, they pick up that infection, and they are the #1 cause of neonatal blindness. So that's why we automatically treat everybody with that erythromycin. I mentioned the retinopathy of prematurity. That's where when we give too much oxygen to NICU babies, and we actually cause blindness because it causes constriction of those blood vessels in the eye and cuts off blood flow. It could be trauma. It could be various infections. Lots of things can cause visual impairment. So some of the visual impairment things that you may see, refractory impairments are the ones that most people think of. This is where you have your nearsightedness and your farsightedness. So myopia is the nearsightedness, meaning you can only see near. You have trouble reading the board. Versus hyperopia is where you're farsighted. You can't see up close to read the book, but you can see the board just fine. And then you have strabismus and amblyopia. So with strabismus, that's the picture on your right, and that's where they have one eye that deviates over to the side, or it can be both eyes, but more commonly it's usually one eye. Could be inward or outward. People call it cross-eyed. And this can lead to amblyopia, which amblyopia is where the acuity is reduced in that eye. So because that eye that's deviated is not working as hard, it's putting so much effort into the good eye, that bad eye starts to lose some of that acuity. So the treatment for both of these is they will actually patch the eye, the good eye, like you see in the picture on the left. And the reason they patch the good eye is so that that one's not working and it's forcing that bad eye to work, and sometimes it can correct itself on its own. So conjunctivitis, commonly known as pink eye, is an inflammation of the conjunctiva. This can be an allergic conjunctivitis, it could be viral, it could be bacterial. This is another one of those things they pretty much always give eye drop antibiotics for this, because there's very little difference in the presentation of a viral conjunctivitis and a bacterial conjunctivitis. So a lot of times they'll go ahead and just treat it. It is extremely contagious, as I'm sure a lot of you know, passed by contact. So treatments for this is the topical antibiotic eye drops, warm compresses to the eye, Symptoms often are related to intense itching or irritation, might feel like sand is in their eye. They might have frequent tearing. They might actually have yellow or white discharge. Sometimes they'll wake up where their eyes are glued shut, where that discharge has dried up. So important things with antibiotics for this group, the child should be not returned to school for at least 24 hours after they've started the antibiotics. So once they've been on antibiotics for 24 hours, they are considered no longer contagious, and they may return to school. This rule also applies to fevers. Now, this isn't related to the conjunctivitis, but fevers in general for peds that you're going to want to know is the child should be fever-free without any antipyretics whatsoever for at least 24 hours before they return to school, or on antibiotics for 24 hours. And then the last thing I'm going to talk about is retinoblastoma. This isn't a very common tumor, and usually it does have very good outcomes. But I'm sure you've seen it where people will talk about they save their child's life by taking a picture. So what happens with a retinoblastoma, it is a tumor on the retina. When you take a picture of somebody, especially people who have lighter color eyes, they'll have what's called a red reflex. And I'm sure you've seen it, and especially with older cameras, where they got the glowing red eyes, and it's where the light from the camera is bouncing off the back of the eye, making them look like their pupils are red. Well, when they have a tumor in the way, as you see in the top picture, they get what's called a white reflex, where it looks white instead, and that's where it's bouncing off the tumor instead of the retina like it should be. They also can get a hyphema, like you see on the bottom left, where the blood starts to fill up in the pupil, and obviously the one on the bottom right is a pretty severe case. They often they'll have that eye removed depending on the severity. They may go through chemotherapy, but oftentimes just removal of that eye is enough. But it is good to know, at least be familiar with retinoblastoma.